Today we'll be talking about this not new molecule of we've been often discussing on many occasions about this because it's a common topic and it's a new drug in the town, and that's the reason we have been talking about. We'll be discussing the role of PCAB in GERD. So GERD is a very common problem, gastroesophageal reflux disease. So it is basically defined as the retrograde flow of the gastric content into the esophagus or oropharynx and sometimes the respiratory tract. There are a lot of instances the patient will be coming with disturbance in the throat. You will see he's been taking antibiotics on and off, but the cause sometimes is something else. The troublesome symptoms may be considered to be moderate to severe, and they can occur on one or more days per week. Now, it can be classified into two basic distinct categories. One is erosive esophagitis and second is a non-erosive reflux disease with symptoms alone. Now, if you talk about the prevalence, the NERD and the esophagitis, they share a very huge amount of prevalence globally. Talking about the NERD, which is of course 60 to 70%, and the erosive, which is the most severe form of illness, accounts for almost 30%. Now, almost 13 to 20%, they are globally affected with it, and almost 50% have GERD like symptoms, at least one in their lifetime. That makes it a very common problem because everyone, whether it's a patient of acute illness or chronic illness, they have been suffering from this kind of thing very often. So burden of disease in India is also pretty much variable, but the prevalence ranges between 7.6% to 30%. There are various risk factors which have been highlighted. First is the older age. Because of this, there is a lax in the sphincter, and then there is a higher chance of regurgitation of the contents. Going to sleep immediately after the meals. Again, pregnancy, smoking, obesity, high fat diet, diabetes, carbonated drinks, consumption of excess of coffee, alcohol, and definitely the medication. So all in all, there are various risk factors which we have been all prone to, and that's the reason why we develop GERD very often. So the GERD symptoms can range from the typical symptoms like heartburn or regurgitation. They can be associated nausea, vomiting, bloating, belching, or epigastric pain, where they are atypical symptoms which might present with a non-cardiac chest pain. This has been often encountered in so many times in the emergency, where the patient will be coming and the patient will be explaining that there's a tightness in the chest, and this again on doing the ECG has been ruled out, and he has been a patient of GERD. There can be chronic cough, as I suggested, hoarseness of the voice, reflux asthma, reflux dental enamel erosions, and nocturnal awakening. Because we try and relate to so many other diagnoses because of this, but they are all overlapping symptoms of so many other ailments. But while ruling out of them, we get to the diagnosis of GERD. There can be some of the alarming symptoms. What I always say, a red flag sign. It can be in the form of dysphagia or odynophagia. There can be GI bleeding. The patient might be presenting with a melena history. We might need to take that as well. Weight loss is something also which is on the long term basis also associated, and of course anemia. We need to find out the patient whether the patient is anemic or not. So the pathogenesis. So there are various pathophysiology which has been shown over here. One is decreased salivation. Then there is a decreased esophageal clearance. Hiatal hernia is one of the predisposing factors for this. The lower esophageal sphincters dysfunction. Now this is very common, as I told you, as the age advances, and there is an increased transient lower esophageal sphincter relaxations. There is also increase in intra-abdominal pressure because of obesity and other factors, and delayed gastric emptying. All in all, they pose the patient more prone to develop GERD. There is a clinical spectrum of disease, right from the physiological reflux to symptoms of GERD, NERD, esophagitis, and then ranging to a complicated form of illness, which is a complicated esophagitis. Now, the symptoms of GERD, NERD we have already talked about. The esophagitis will be more severe form of illness, which is erosive esophagitis, and the complicated versions, they can present with a complication like strictures, Barrett esophagus, or the more severe form, esophageal adenocarcinoma. Now, once we talk about the diagnosis, most of the time it is clinically made, but we have to rule out other diagnosis. Why? Because this is one, once we start treating it, we have to rule out other symptoms who are involved. So clinical symptoms will be guiding us towards the diagnosis. Of course, we have to do a PPI trial. The PPI have been the first and the foremost drugs. They have been mentioned across the globe in majority of the GI guidelines, and this says it's a PPI trial which needs to be initiated in majority of the cases whenever you are suspecting a GERD. Apart from that, upper GI endoscopy is also one of the important ways which can tell us about this diagnosis. Esophageal manometry studies, barium swallows, and of course 24-hour pH monitoring. Once we talk about the the management. Now the management starts with the lifestyle modification whenever we talk about any chronic ailment. So again, avoiding triggers for reflux like coffee, chocolate, spicy foods. Avoid eating large meal, instead eat small meals and the frequent meals, especially late night. Weight reduction is very important. Stop smoking and minimize alcohol as much as possible. Attempt to sleep on the left side. Why? Because that's been one of the ways you can minimize those kind of symptoms, especially the nocturnal symptoms. Avoid lying down 2 hours after the meal, and elevation of head and of the bed is usually advisable once the patient is having chronic symptoms of this kind. Now the mainstay of the treatment remains as such over the years, that has been the suppression of the gastric acid secretion. The management of the acid peptic disease acid approach since 1960s, initially there were antacids, later it was H2 receptor antagonist, and then the PPIs came. Now we have PCABs. So there have been array of the drugs over the last 50 years or more which we have witnessed. The initial ones were only in the form of basic acid suppression or acid neutralizing agent, then H2 receptor antagonist, PPIs and PCABs. Now they are in the market. Apart from that, if you talk about the pharmacological management, we have antacid, which are basically the acid neutralizing agent. Now the prostaglandin analogs, these are ulcer healing agents, so they act differently. Alginates again prevents the reflux. They are not usually effective alone, they need to be combined along with the PPIs so to get the best results. Ulcer protective agent like sucralfate or the bismuth, prokinetics like metoclopramide and domperidone, H2 receptor antagonists we already know about, cimetidine, ranitidine, famotidine, nizatidine, and then of course the PPIs, the proton pump inhibitors. We've been using this drug since very long, very well established safety and efficacy. Omeprazole, esomeprazole, lansoprazole, pantoprazole, and of course the rabeprazole. And now the potassium competitive acid blockers. Vonoprazole is already there in the market. We have other drugs which are bound to come, rivaprazan and tegoprazan and fluoxaprazan, which might come in forthcoming years. The vonoprazan is the one which have been there with us. It has been a USFDA approved drugs for the various indication. Even the DCGI is also given that approval. The main target of the pharmacological treatment is the gastric proton pump enzyme. Now this is the area which has been primarily targeted by this agent, and the proton pump transports equal amount of hydrogen and potassium in order to maintain the electrical equilibrium, and therefore the availability of potassium is essential for the maintenance of the proton secretion. Now the proton pump is competitively binding to the potassium binding site, and this PCAB helps in the suppression of the gastric acid by doing this in a sustained way. Now it is not a transient thing. What is more important in this molecule, it is a sustained action which has been more rapid as well, and that too on long term basis it is more stable and very long lasting, which is making it more preferable agent these days. Now the PCAB reaches the gastric lumen, it binds to the E2 form of the enzyme, prevents potassium binding to the enzyme, prevents the conformational change in the enzyme, and of course thereby doing the acid secretion suppression. So the profound and prolonged action of the PCAB, vonoprazan, is the one which has been more closely linked to its safety and efficacy. What they say is it covers both day and night time symptoms. Now the proton pump inhibitors, they are not very effective for the nocturnal symptoms. The patient used to have NERDs, those kind of symptoms, or nocturnal symptoms. So all those symptoms couldn't be really effectively controlled by the proton pump inhibitors, because the patient might be taking these drugs usually in the breakfast or before the breakfast, and there was a mealtime relation to these. Whereas with these kind of drugs there is no mealtime relation, and there is a sustained blockade of the acid secretion throughout the day, and even the nocturnal symptoms have been very effectively controlled with this. So now these are the salient features which they've been highlighting very often. There's a rapid onset, potential coverage, and of course the durable action which has been linked to it. It has got a high solubility, lipophilic, stable in acid, good amount of pK, and accumulates rapidly into the gastric canaliculi, thereby increasing the pH above 4 as early as 4 hours and maintain it almost for 24 hours. This is very important. The onset of anti-secretory activity also happens very quickly. Now the effect continues without intragastric pH dipping below 4, which is a rapid onset, and it is also sustained once compared to other proton pump inhibitors, approximately 350 times more potent inhibitory activities than the PPI. Now very important thing is the studies which have been done with the PPI lansoprazole, they say the 20 milligram dose of the PCAB vanoprazone, they have compared to 30 milligram of lansoprazole, but no, it is not correct. Why? Because theoretically 60 milligram of lansoprazole is equivalent to 30 milligram of vanoprazone. That's the reason the effect is slightly superior in vanoprazone and slightly less in case of the lansoprazole. But had they compared in this study which was been done, they could have found out that there was no distinct difference between these two categories of drug. The dose changing has been done. Sustained acid suppression, long half-life, slow dissolution from compared from the proton pump inhibitors, and reversible binding to the proton pump, slow clearance from the gastric acid parietal cells, longer retention time in the gastric mucosa is the main feature, and it maintains the acid for a long time, high concentrates in the acid canaliculi, and acid secretion inhibitory activity was sustained for 24 hours. It is metabolized by multiple enzymes, and CYP2 C19 partially contributes to the metabolism, and it contribution is considered to be small. Now the drug interaction will be interesting to see, although they might have not shown it, but it has to be given with a caution along with the anti-epileptic drugs, sodium valproate and other class of drugs. Apart from that, antiviral and certain immunosuppressants. So like PPIs, these drugs have got a drug-to-drug interaction, and with those categories of drug, it's an acid suppression irrespective of meals. If you compare it, the acid stability is pretty much there, and the reversible inhibition of proton pump is there. Onset is rapid, and it both acts on active and inactive pump, which is making it more superior a molecule compared to the conventional PPI. Theoretically, it is right, but practically how much difference we are seeing in our clinical day-to-day practice, that needs to be really understood, because majority of the PPIs which are there in the market, they are in the combination of prokinetics, and that is how they've been used for the treatment of GERD. Whereas till now vanoprazone which has been available, they are only available as single agent. We do not have any combination along with the PPI prokinetics. That is the reason it is only causing acid suppression till date. It is not acting on any reflux symptom. It is not benefiting the patient in terms of anti-reflux activities, because of which we might need to combine either prokinetics or alginates for giving a better response to the patient. So again, these are the studies they've shown, which shows that it is more valuable and better than the PPIs. Significant healing rate in esophageal esophagitis, faster relief from the heartburn compared to the lansoprazole. But majority of the studies of lansoprazole, the dose ranging has been incorrectly done. So once the dose ranging or the dose comparison has been incorrectly done, you are more liable to see the benefits of vonoprazole, and which comes as a bias. So as I've shown you, 30 milligram and 20 milligram. So the equivalent dose of lansoprazole should be 60 milligram in this case. Only then you will see a standard study coming out. There the dose has been dropped just for the comparison purpose, and it is seen in majority. You see the majority of the studies, the dose ranging of the PPIs have been kept under lower dose, and this has been used on the higher dose scale, and that is how they have shown that the better results are coming out. It also significantly reduces the recurrence of rates compared to the lansoprazole. Of course, better healing rates and maintenance therapy is better, they say, and again, they re-randomized those patients and given vanoprazole, and they found better effects. Heartburn symptoms have been very well controlled, and NERD symptoms have also been very well controlled once they've been compared head to head and they've been compared to a placebo in this study. Effective for heartburn in non-erosive esophageal diseases, and on-demand vanoprazole can also be given for the patient on short-term basis, and it gives a complete and sustained release within 3 hours. So in GERD, it has got better pharmacodynamic properties, rapid action, sustained acid suppression, prolonged elevation of the pH, and enhanced symptom controls, relief of the heartburn episodes within 3 hours, faster healing of the mucosal lesions, better nocturnal heartburn control, lower recurrence rates, and effective in PPI resistant esophageal otite. Now the dose. Apart from this drug has also been approved in the management of the H. pylori infections. It can be given as an alternative to the PPI, and now the FDA has also given approval for that, wherein they have been showing the studies of this molecule's safety in the management of the H. pylori eradication therapy, and it is very well synergistic with the antibiotics which are given alongside of the bismuth salts in the H. pylori eradication therapy, where it has been found that it has got a good ulcer healing property compared to the conventional pantoprazole. Heartburn associated symptoms: 10 mg OD for 20 weeks, erosive esophagitis 20 mg for almost 8 weeks, and maintenance for 6 months. That is what they say. But the standard dosing is of 8 weeks, and the dose to be initiated is 20 mg. The only difference what we see is, initially with the proton pump inhibitors, we start at the lower dose, and in case of non-responders, we try and go on the upper scale dosing. Whereas in this case, we have to start with a higher dose, and once the patient gets relieved, we can downscale the dose to 10 mg. It has also got excellent properties, as I have already shown to you. This is a repetition of the same. Prolonged acid suppression, they have repeated it, complete relief. So this is the molecule Aristos has been promoting. These are the sponsors today. Well, thank you.